Yeah.
Yeah. Well, in reality, I think most of this stuff, it's not as complicated as it seems. Like
Hmm.
it's not, it doesn't really take, a PhD in neuroscience to understand it. It's mostly like, the terminology, the jargon, which is
Right.
a big, big barrier. It makes it hard to explain. And this is one reason um, why I created the model. It's derivative of a model that like my postdoctoral advisor made many years ago. His was simpler and only focused on the core, and then I've kind of expanded it to capture the voltage sensors, and the reason I've done it is because I find that it's a good representation of the way I think about these questions. And it shows that it's not that complicated. It's
Hmm.
just expressing it in English is complicated in
Right.
a clear way, because you're describing a 3D structure that is moving in time. And it's just not that easy to explain. But the physical model, while it's not perfect, it doesn't capture everything about sodium channel function. It does paint the broad strokes, and I think it's useful for a lot of people, especially if you are like me, a visual thinker.
Yeah. Well, I think that's awesome, just to maybe, I think you do like saying that like helps people stop thinking like, oh, this is like 10, 10 times beyond my level of understanding. And it'll just help people kind of, okay, I can get this, so
Yeah,
yeah.
and there's multiple levels. Well, there's layers of because you can talk about it just at the level of the protein, but
Mhm.
then you take it to the level of a neuron, and then you take that to the level of a tissue, and then to the level of a person. And if you're trying to understand them all at the same time,
Mhm.
your head wants to explode, right?
Right.
But if you break it down and just take one piece at a time, none of it is all that prohibitively complicated.
Right.
Um, well, until you get to the level of the brain, then it gets too complicated for any of us to understand.
Okay.
Yeah.
Right. All right. Well, maybe we'll just do a quick intro so it's like a good starting place for the video. All right. So thanks for joining us. And JP, we're so excited to have you with us. Today we have JP Johnson, who is VP of Biology at Xenon Pharmaceuticals, who developed XEN901, which is now the Neurocrine drug that is about to get ready for clinical trials. So congratulations. Well done.
Thank you. Thanks,
um,
thanks for talking to me.
yeah. Oh, we always like talking to you. But today we're excited because JP has actually built a model of SCN8A that he's going to use today to help us better understand what's actually happening down at the cellular level. So go for it. And we'll probably
Great.
chime in with some questions and clarifications. And thanks for doing this.
Yeah, feel free to interrupt me anytime. I love talking to the parents and families, because this is what motivates me to keep coming in. The drug discovery is fraught with failure, and it's challenging, but having people on the end waiting, that's what keeps us excited. So this is my very fancy model that was made in my garage with the help of my daughters, to illustrate how a sodium channel works. And I'll try to get this where it's well captured in the frame here. But so what you can see is that there are there's a repetitive motif here. There's four of everything. There's four of these cylinders out here. These are meant to represent the voltage sensors in the channel. And then there's four of everything else. So you can see that we got a red, green, purple, and blue. And Tyler, for the more scientifically minded people who want to look at the crystal structures, these are painted to correspond to the crystal structure in the NAV 1.7 crystal structure. So each of these pieces of it are very similar to one another. They're not identically, they're not identical to one another, but they are similar, and they're all hooked together. In some channels, like a potassium channel, you actually have 4 separate proteins, which are just like one of these 4 bits that they all come together to make one channel. But in the sodium channels, it's all one protein. And it sits in the cell membrane, or so the cell membrane would be out here to the sides. And so this is looking at it from the side, from within the membrane, or here, this would be looking at it from the outside of a cell. And the sodium comes through here and out the other side to the inside of the cell. And if you look here, this is basically wide open. Sodium can go straight through there if, or any ion that's exactly the right size can fit right through there. But on the other side, let's see, there's a gate that contracts and opens to stop the sodium from going in or allow it to go in. And you can see I'm kind of twisting the channel to make that happen. And that actually is what the protein does, is it has this twisting motion that closes and opens the channel. And it also, you'll see, if you look at these cylinders out here, these voltage sensors, they move as you twist the channel. They sort of rotate, and they move up out of the top of the protein. You can see up and down, up and down. And so I'm twisting the channel and making the voltage sensors move, but in reality, it's kind of the opposite. The voltage sensors, these have a lot of positive charges on it. And the inside of a cell has negative charge. And we all know that like opposites attract. So the cells, the negative charge inside the cell holds these voltage sensors that are positively charged down. And when the inside of a cell gets more positive, it repels the voltage sensors, pushes them out. And when that happens, they pull the rest of the channel to follow them. And but the channel doesn't want to stay open very, very long, because if you were to do that, too much sodium would come through and it would cause all kinds of problems. You want to avoid that. The cell has to actively consume energy to push the sodium back out. So you don't want to waste that sodium. So you want the channel to be open briefly to send a signal. It's almost like if you were trying to send a message in Morse code with a light. If you leave the light on all the time, there's no message. And if it's off all the time, there's no message. You get a message by blinking the light in a pattern. And that's what neurons do, is they signal in patterns, and the channel opens and closes in patterns to facilitate that. So, so part of that is the channel most of the time will be closed. It briefly opens, but if it stayed open, that would be a problem. So then we have this secondary way of closing the channel. It could, in theory, go back this way, but if the neuron is excited and it's still positive inside, these voltage sensors can't go back down, so the channel can't close in the normal way. Instead, there's a second gate, we call the inactivation gate. It's kind of out of the screen here, but it hangs down below. And so this is a loop of the protein that connects the domain 3 and domain 4 of the channel. And this loop is like, makes like a knot of protein that comes up in here and just blocks the channel. And so once that's in place, there's no more sodium going through. We call it the inactivated state. It's another closed state. So it's like there's really two doors on the channel. There's the original gate of the door that goes when the channel goes from closed to open, and then we have a second door that closes that makes the channel what we call inactivated. And still no sodium is going through there. So now for the channel to open again, it has to go back to a closed state, kick the inactivated gate out, so kick out the second door, and now everything's ready to go again. So most sodium channel blocking drugs actually bind down here in this gate. And they do two things. One, they block sodium from just going through the channel so that sodium doesn't go through. But also they hold the channel in a state where the inactivation gate binds more firmly, so that it makes this door shut more strongly, so that it's less likely to come back out. And that's because the shape of this shape of the channel is encouraged by the drug. And that's how most things like carbamazepine, phenytoin, that's how those drugs block the channel. But there's another class of compounds, and that including the compounds that we have worked on at Xenon, that bind to a different part of the channel. And they bind to the voltage sensor. So they bind to these cylinders that are sliding up and down when the channel opens and closes. And so XEN901, and there are some other compounds, mostly that have targeted NAD 1.7 channels, but they bind, and there's also some, I should say, there's also some protein toxins, like from spiders and things like that bind out here. So they bind here and lock, they basically wedge in between the cylinder and the rest of the channel and hold it there. So as long as those voltage sensors are stuck in the up position, the channel will stay in this inactivated state. So until you force them down to kick off the inactivated state, the channel is stuck in this state where no sodium can go through. And if you were to push it hard enough, you could force the drug off by more or less kicking it out of this spot. But the voltages that it takes to do that are very, very high, and generally aren't going to happen very much in physiologic conditions. So that's more or less what happens is this class of drugs, these voltage sensor drugs, they bind out here into the VSD4. So that's the S4 of the voltage sensor for the domain 4. And that's where they bind. They lock the voltage sensor up and prevent the channel from going through its cycle and functioning normally. Now, a lot of the mutations in patients actually change part of this function. So they usually will do something like they'll disrupt the ability of this inactivation gate to bind, so that it binds more sloppily now. It's not as stable, and so it will fall back out, and that results in more sodium coming through than should. You can also have mutations that make the channel more likely to open. Like it doesn't take as much of a push on these voltage sensors to pull the channel open because you have destabilized the resting state of the channel and made it more likely that the channel will open. And most of the mutations, oops, I've broken my model here for a second here. I think I need a little glue, but so yeah, most
You lost domain 4, and you lost the voltage sensor from domain 4.
yeah, you know, when you make prototypes, sometimes you have to follow up with a more advanced Mach 2. But this most of the changes that the patients have to do with either making the channel easier to open to start with or harder to close the second time, the second gate. And so that's what makes them gain of function. Now, for loss of function patients, and you know, most of those patients don't have seizures, they have other issues. The loss of function either make this more stable and make this second closed state more likely to happen and more robust, or they make it more difficult for the initial opening of the channel to happen. And because all these pieces have to move kind of at the same time, it's not always intuitive, like that this piece will affect this part of the function versus the other, because you know all the parts are interdependent, they all move together. And so sometimes a mutation over here can actually impact the movement of this part of the channel, even though they're not necessarily close together. So does that make some sense?
Yeah, that's really good. Any other questions? I had a question about, so what is persistent current? And are there drugs that target persistent current in a way that you did not describe?
Okay, so persistent current is when you have, so normally the channel starts closed, it opens, and then it inactivates. So persistent current is when that cycle is somehow interrupted, so that usually it's that this inactivation is disrupted. So maybe instead of binding and just staying there, it binds and then it falls off, and then it binds again and it falls off. And that sodium that's coming through during those inappropriate openings, that's persistent current. And there are people who have targeted that. So the Praxis folks have specifically gone after compounds that will just block that persistent current. I would say that most of the drugs that are out there, so sodium channel inhibitors, do inhibit persistent current because they will stabilize this inactivated state. However, they do it with some compounds have very different kinetics, or that's the fancy jargon word for saying they do it with different speeds. So, you know, some compounds will very quickly bind to the channel and stabilize a certain state, some very slowly, and that may impact how they function in physiologic settings where the channels are bouncing back and forth. So the approach we've taken, we have compounds that equilibrate slowly, but we think that they will capture the channels sort of in this inactivated state robustly. because in normal situations, the channels are moving all the time. They're going back and forth between closed, open, and activated states. And at physiologic voltages, that happens on a pretty rapid time scale. So you have the opportunity to bind the inactivated state. And if you have a compound that binds that very strongly, you will over time accumulate most of those channels in the inactivated state. So, so we think that that is a good approach, but it's hard to know how important the kinetics are until you really test that in the clinic, because there's just too many free parameters in the system to know for sure.
Another thing you might want to address is that your drug is selective, whereas the other existing drugs are not. And you might want to say a few words about that and why your drug is selective in the pointing to your model is the example.
Yeah, so that's a good point. So yeah, we took the approach that a lot of the problems with existing drugs, right, where they do work, they reduce seizures, but you get to a point where you have problems. You can't dose any higher because the kids get sleepy, they get, people get confused. There's, they may get nauseous. There's all kinds of problems. You go high enough and you effectively put them into a coma. And so our idea was that if you can strip away some of the activities of the molecule that aren't necessarily helping to control the seizures, then that would make a compound that is more effective at controlling the seizures, but also better tolerated in other ways. And that's our hope, is that by making a compound that just binds the 1,6, NaV 1.6, that we should be able to control the adverse problems associated with the gain of function of those channels without bringing with it a lot of other effects that are caused by blocking other things. So, that's our approach, is kind of like a targeted approach. Let's just fix the 1,6. Let's dial back the inappropriate 1,6 activity and try to leave everything else alone. So it's kind of an obvious approach for people that have a NaV 1.6 is too active. So the SCN8A gain of function people, that it's natural. Then the question is, are there other epilepsy patients that could benefit from that same mechanism? We think so, because we think that the gain of function patients, they're telling us something important, that 1.6 is really critical in controlling the excitability of the brain. And so we think that this will also apply to people who don't necessarily have mutations in NaV 1.6, but still have neurons that are more active than they should be. And so we were hoping that this approach will also work in more patients.
I had a question going back to your reference that different variants have different impact on the effectiveness or responsiveness to existing treatments. Stop. So my question is this going to be less of a problem with this compound, or is there likely to also be variations in its impact for people with different variants? Basically, lots of our kids have very different responses. One sodium channel blocker is great for some kids and it's not for other kids. So is it more likely here that this will be effective for a broad range of variance, or might we expect similar variation in impact?
Well, I'd say we certainly hope that there'll be more, it'll be more broadly efficacious in this population, at least the gain of function patients. It's hard to know because there are many complications to this. Nobody has people aren't identical outside of their SCN8A variants, right? I think I've heard it, and don't quote me on this as far as this being exactly right, but everybody has about 70 mutations on average. We're all born with 70 mutations. A lot of them are silent, you don't notice them, but they're different. And that's, spread across your whole genome. Michael probably knows the number better than I do, but
very good number you had there.
but the point is that there's other genes involved. This isn't completely monogenetic. Certainly you have one gene that's the biggest player, but you can have other genes that actually that compensate or offset this. So you're never going to find anything that's totally acts the same way in every patient. We hope that this will be a tailored approach for gain of function mutations in SCN8A, and that it'll work well in those patients. Hopefully that pans out. We do expect that there may be some particular mutations that are less receptive to this approach. So you can imagine, for example, if you had a mutation that bound right where our drug, or where a mutation right where our drug binds, that could cause an issue, right? Because there's a little pocket that our drug binds in, and if it doesn't bind there, or if the mutation can disrupt that pocket, then you might impact the ability for the drug to bind. And we don't know how big of an impact that would be, but you certainly can imagine that there probably will be some patients, at least a few, where the drug is not as effective as for patients that have mutations elsewhere in the channel.
Right.
But folks like that wouldn't be excluded from a trial. You just watch it and potentially observe different impacts for variants that are close to where this compound binds.
So I can't say for sure how Neurocrine is going to handle this. I don't know exactly how they'll handle it. But I would say that at the very least, they would want to watch to make sure that they don't have a preponderance of patients that have a mutation that you expect to be problematic. But I don't know really what the final plan is. So I don't want to speak out of turn on that front. And yeah, I don't expect there'll be a lot of mutations that fall into that range, but there probably will be some.
Mm-hmm. And just so families understand, when we talk about modifiers, that's what you're talking about, that if you have other mutations that might affect how one kid responds differently than another kid to a drug.
Yeah.
And I know in our community, we've had a fair number of kids who've maxed out on oxcarbazepine, and then, it got toxic, and that is the drug that seems to work the best for the most kids. And so having a drug that is much more targeted and that has less side effects is going to be incredibly attractive to a lot of families. And hopefully, we'll see what happens with clinical trials. There's still a long way to go. And they'll be starting in 12 and over. And then hopefully, the younger, the 2 and under, the 2 to 11 will come down the line, hopefully not too much further behind. And then we'll really learn kind of how this works. And
yeah, fingers crossed. I mean, we're excited to see what happens.
Yeah. When did you start working on XCN901? How long has this been in the making?
So I joined Xenon in 2014,
Hmm.
and I was recruited by Charlie Cohen really for this project. At that point, it was mostly an idea. We didn't have a whole lot in place. You know, they had been doing some work, but it was kind of like on the side of people's desks.
Right.
So 2014 was when we got serious about like really putting a program together and really starting to look for compounds and design new compounds.
Hmm. And I'm curious, what was it that was attractive about SCN8A as opposed, I think in 2014, I mean, that was very newly, Michael had discovered it as pathogenic for epilepsy in humans in 2012. And yeah, the ball is not early. Those are very early days. Yeah.
Yes, you're right. Those were very early days. Well, I'll admit that when Charlie first called me and asked me if I was interested in a job and that this was the topic, I said, "Ooh, are you sure you want to block NAV 1.6? I mean, it's pretty important." I'm like, he's like, "Well, yeah, we think maybe it's a good idea." So I sat down with the literature and poured over it. And before I came for my interview, and I was like, they might be onto something here. It might be okay. And really, it was a couple of things, right? It was Bill Catterall really had built a story where about the Dravet patients, which were loss of function in NAV 1.1. And he had this hypothesis that if you blocked NAV 1.6, you could rebalance the system. So we were really thinking about Dravet syndrome at that time. And that was the initial thought for the project, was to go after Dravet syndrome. And Shay's mutation and Michael's paper on Shay's variant, really, that was like a critical piece of data that just said, okay, look, this story that Catterall's pitching, is holding together, right? So Shay's variant says that if you have an overactive 1.6, that causes epilepsy too. And so initially we were not thinking that, we thought Shay was the only one, right? There, maybe there's somebody else out there. This is not a population that you could target. But as the project went on, more and more patients started showing up. We started hearing from you guys, started hearing from the Cute syndrome, and we started realizing that, well, maybe there are enough patients here to make it worthwhile to push our project specifically towards SCN8A patients, and that's where we kind of evolved to into that approach.
Wow, that's really fascinating background. I didn't know. Well, we'll have to say thanks to Charlie, and obviously Michael, thanks for writing your paper, getting us where we are today. It's kind of incredible, and I think the community is really excited about this progress and what we're learning. Tyler, do you have any questions?
My questions are probably extremely technical, and I can ask them anyway. So JP, the region that the XEN901 now Neurocrine, I don't remember the number off the top of my head. Drug
921352.
921352.
921352 targets in that kind of selectivity zone is an area that shows differences between the sodium channels. But even in that region, there's a slightly increased homology between 1.6, 1.2, and 1.7. Are there thoughts of, did you guys look at any sort of drugs that would say kind of dual target 1.6 and 1.2? or say 1,7 alone, because that's a different target that's like pain type of pain medication.
Yeah, in fact, it's not well advertised, but a lot of the compounds that were really developed for 1.7 actually block 1.6 and 1.2 almost with the same potency. And in fact, we think that that's, you know, a challenge for those drugs if you're looking at them for pain, because you don't want to block a lot of 1.6 and 1.2 when you're targeting pain. At least we that would be a hypothesis. But yeah, so definitely we started out looking at compounds that kind of blocked all three. And we really wanted to focus to get rid of the 1.7 and strip it down to just what you need, right? What do you need? And we didn't know, maybe still don't know, whether you really need both 1.6 and 1.2 or only 1.6. Now, that'd be especially true for, you know, more general patients, not gain of function SCN8A patients. But we were kind of agnostic about whether we have something that only blocks 1.2, or sorry, only blocks 1.6 or blocks both 1.6 and 1.2. And pretty early in the project, the chemistry diverged. We noticed that certain compounds we made tended to be more potent on 1.6 than 1.2. And we exploited that, and we drove the chemistry in that direction. In fact, we drove both sides of it. We drove compounds that blocked both and compounds that only blocked 1.6. And we still have, compounds that in both categories. And in fact, some of the compounds that that are in Neurocrine's hands block both 1.6 and 1.2. Some are aimed just at 1.6. So, you know, I think for an SCN8A population, it makes a lot of sense that a 1.6 targeted drug, you know, should, in theory, be the best combination of safety and efficacy. In other populations, that may not be true. It may be that adding the 1.2 gives you more benefit. And I mean, to be completely fair, until we have data in the clinic for both approaches, we can't guarantee that the dual approach wouldn't be better for the 8A kids. But I think just intuitively, the simplest picture would be that a 1.6 specific treatment should be better for those patients. But yeah, we made both types of compounds, and we're still looking at the, you know, the possibilities. If it turns out that just blocking 1.6 isn't enough, then we would have the option to go in with something that blocks 1.2 as well.
I also wanted to bring back when you talked about that basically 1.6 in the beginning, you're like, well, you don't really want to block that, right? I mean, and I think that's very interesting, the difference between Dravet and 8A, right? Dravet, my understanding is that you can cut it off and without more issue. But like, for example, the work that Miriam Meisler has done with her ASO, right? It will work, but it's got to be titrated, right? You can't completely shut off 1.6.
Oh yeah, that would be bad.
Right. So it makes it more complicated to come up with a genetic modifier kind of. We're obviously getting off of the work that you're doing with N01. Now I'm just chit-chatting, but yeah. Yeah, so that's, I think it's important that families recognize, you know, you can't just shut it off. You can't just, you know, turn it off and expect things to be better. It makes it more complicated because you need it to be functioning and sodium flowing, but it's got to be at the right levels. Yeah.
Exactly. It's all titrating, you know, getting just the right amount of activity. And that's, you know, part of the reason why we went with this selective approach, is that the idea is that it will allow you to pick exactly how much 1.6 block you want
Mm.
without worrying about like how much of everything else you're blocking, right? Because, you know, maybe with carbamazepine, or oxcarb, you're not blocking as much 1,6 as you would like to for efficacy, but you've got too much 1,2 block or too much 1,1 block,
Mhm.
and that's limiting your ability to go higher. And so our hope is that by just going after the 1,6, that you can dial in exactly the right amount of 1,6 inhibition
Mhm.
and not be worried about all the other things the drug might be doing.
Right. And inhibition and excitation, those are two words that people hear. But so the inhibition is blocking, slowing down the flow of the sodium, and excitation is that there's just too much flow. Right.
Exactly.
Yeah. Yeah. And that's what causes the seizures is the
Yeah.
Yeah.
The too much excitation, and of course you have neurons in the brain that do both, that go in opposite directions. You have neurons that quiet the brain, and you have neurons that excite the brain, and that balance is what's key, is that you have that right balance. And in Dravet, the neurons that are quieting the brain are underactive, and in SCN8A, the neurons that are exciting the brain are overactive.
And that's the gain of function, loss of function difference. Yeah. Mhm. You're muted, Jayada.
I have a question that may be too far reaching, but I'm sure you've thought about it, even if it's not something that's examined in trials. This is the first compound that is explicitly targeting 8A, as you said, with this selectivity. So it's like going to the root cause of the underlying problem for lots of our children, or at least that's the understanding, that their overall condition is really the poorly functioning sodium channel. Is there any expectation that if this corrects it well, that there may be some beneficial effect on all of the other comorbidities that our children face that seem to be related to their SCN8A mutation?
That's the dream. That's what we hope. We won't know until we try it, but that's certainly what we hope.
We have to be careful to also not, our children have had years and years of seizures. So there's damage that's done to the brain that won't be repaired, but this can stop more damage from happening. And so potentially there could be increased development, but it's not gonna all of a sudden make our kids, typically functioning.
Right. I imagine that there's no way of immediately making them neurotypical right away, but our hope is that this would push them in that direction.
Yeah, that is the dream, I tell you.
What did
There's a lot of us who have kids who don't walk or talk or eat, and to dream of it someday, I think it's exciting, and there's some hope. So it's fantastic. So you keep doing the work.
We're not going to stop.
No, you're not. You've been in this. You were at our first meeting in 2015. You've been with us the whole time. So
Exciting stuff.
it is. It is.
You guys really keep us motivated. So we depend on you to keep us coming into the lab every day, despite the fact that a lot of things don't work.
I know, it's really amazing to look at those graphs of drug development. It's like very narrow. So we still have hope, but there's still a long way to go.
Yeah, there's still a long way to go. And, but, we're taking those steps. So hopefully, I've got a lot of confidence in Neurocrine. They have a lot of experience developing drugs.
Mm.
I think partnering with them really gives the drug the best chance that it can have, because they have the bandwidth to do it right.
Yeah, right. Well, it's moving, so that's good news.
We're
Great
very
news, yeah.
grateful.
Yeah.
Well, I'm grateful to you guys for keeping us on our toes.
Don't worry, we will.
Reason.
We'll keep bugging you.
Hey, thanks very much, JP, for doing this. This is great. Really appreciate it.
Not a problem.
All right. Well, we'll bug you again soon.
All right. Well, I'll look forward to it.